So thank you, everybody. Thank you to be there. As you may know, now Enovis, it's a new brand, and it's a merge between Mathys and DGO, and it's a new word now for us. It's innovation and vision. So if you want to speak about innovation, I think we always need to go back in the past. And if you look at this slide, most of the time we think that reverse shoulder arthroplasty is coming from Europe and especially from France. In fact, as you may know, it's not the case. The first idea to have a constraint prosthesis has been done by Charles Neer, and it was a failure. As you know, it was a failure because it was a cemented kill. And for many, many reasons, despite the fact that they have had 3 iterations, it was still a failure. So their conclusion were that they said we should not have a constraint component. We should not have this. As you may know, in the meantime, in Europe, a French guy, Paul Gramont, designed a prosthesis, and he made some changes. And he went to this idea to distalize and medialize the center of rotation. And everybody, in the mind of all the surgeons, at least in France, that's what I think, each time that you refer to the reverse shoulder arthroplasty, you refer to this first idea, which is the fact that regarding the fact that you distalize and you medialize, this is why the constraint prosthesis can work. This is why the constraint prosthesis can work. But, so you can see the first draws that they explain the fact that there was a failure with the Neer design because it was not distalized and not medialized. It was the very important word, distalize and medialize. And then, this is true that it works very well. The Gramont design worked very well during many, many years. Especially, I have had the opportunity and the pleasure to work with all the team, as you can see here, and we have seen our prosthesis with between 5 years and 10 years follow-up, and you can see here that the results are good. The results of the Gramont design are good, as you can see here. Whatever the kind of etiology, the results are good, even at 10 years follow-up. And if you focus on the 3 main etiologies, which are massive rotator cuff tear, osteoarthritis, and cuff tear arthropathy, you can see that the rate is very, very high. At 10 years follow-up, almost 95% of the implant are still there, which is a lot, as you can see here. But, there is a but. We have good clinical results, but we have to face to more than 50% of notches. At the beginning, we thought that it was not a problem, but with the long-term follow-up, we know that it is a problem. It's when you have bone loss, it is a problem. And of course, you may know the 4 stages which has been described by François Cirvaux, as you can see here. So in order to avoid this notch, because this notch is a concern, and we tried to modify a bit. We tried to think, okay, the idea was to distalize and medialize, but probably we could try to medialize, to lateralize a bit more on the glenoid side. That's why Pascal Ballot went to the concept of bio-RSA. Just bio-RSA does not mean that you add some graft. For example, if you have a retroversion of 25 degrees and you put a graft in order to correct this retroversion, it's not a bio-RSA. Bio-RSA means that bony increase offset. It means that you decide to lateralize your sphere, your glenoid, with a piece of bone. So the question that we can have each time that we do a graft is the question is, does it heal or not? If you look at the paper from Pascal Ballot, you can see that in almost all the cases, you have a good healing of your graft, almost 100%. Anyway, if you look at this paper from George Arthur, he has published that it's very, very, very difficult to assess the healing of the graft with a CT scan. Even if you let a gap at the lab between your graft and your prosthesis, with a CT scan, you're almost unable to assess this gap. So probably the results from Pascal Belot were good. There is no problem with that. That's probably just a problem of methodology and the fact that it's very difficult to assess the healing of the graft or not. As you can see here, sometimes we think that it's a good healing of the graft, but it's just the coracoid process, as you can see here. So it has been described that we cannot call that a notch, but you can call that a lysis of the graft, which is very close to the notch, but we can call that a lysis of the graft. And you can have no lysis of the graft, as you can see here. You can have a stage 1, a stage 2, or a stage 3, as you can see here. We can call that a notch in the graft, or a lysis of the graft, as you want. But anyway, the graft is not perfect. And you can see here on this slide that you can have on the cases 1 no problem with the graft, and on the case 2 a clear loosening of your graft. So Niolen-Letton has published the fact that he found in his cases more than 50% of grade stage 2 and 3 of graft lysis, of the lysis of the graft. This is one of my cases. As you can see, it's not perfect regarding the healing of the graft. And this is where we are. In the meantime, so this is where we were in Europe. In the meantime, in United States, another guy in Florida went with another concept. But it was overshadowed by the fact that in France and in Europe, it was a Grammont design, and it worked. The Grammont design worked, and the NIR design failed. And it was a third way, in fact, and it has been developed by Mark Frankel. And the idea was the fact that it was probably possible to lateralize a bit on the glenoid side without it is possible to have something which works without distalize and medialize. This was the idea at the beginning. And of course, Mark went to the big master, which is our master and my master, Gilles Walch. And Gilles Walch said, so he showed him his design, and Gilles Walch said, you have not medialized, so you are going to have a failure. And that's what happened. And then it emphasized the fact that you need to medialize and to distalize. But in fact, Mark Frankel was very, very clever, and as he has investigating his failure, and when he has looked at his failure, it was not related to the fact that it was lateralized. It was relating to the fact that the base plate was not well positioned. If you put the base plate with a superior tilt, you will have a high risk to have a failure of the base plate. And look at this slide. If you compare very good implantation of the base plate to bad implantation of the base plate, you can see the difference between two groups. So, and this is the first reason why it's failed, because it was not a problem of lateralization or not. It was a problem of the fact that the base plate was not well implanted. And if you look as well at the micromotion, there was a lot of micromotion because it was non-locking screw, and with locking screw, it was not a problem anymore. So, in other words, now Mark showed us that it was possible, in fact, to have a constrained prosthesis which works without medializing so much. And there had, of course, some problem with exactly the same problem than the Grammont design if you use this kind of the non-monoblock stem, and they have modified the stem. Now the stem is totally monoblock, and then we cannot have this kind of disassembly anymore. So if you look here, you can see that now we have two philosophies. We have the Grammont design, we have the first Grammont design. Then the first Grammont design moves slowly, 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 to what we can call the Frankel design. And as you can see here. And if you look at the biomedical studies, you can see that when you have a 2/3 sphere, as you can see here, on a biomechanical point of view, it's very, very, very good. As you can see here, even if you lateralize with the bone here, you still have some, as I said, some problem with the inferior part of your graph, which is not the case with the 2/3 sphere. And furthermore, if you look at the balance, muscular balance, if you use a 2/3 sphere, it's better. So as you can see here, this is a normal shoulder, and what we need to understand now is the fact that reverse shoulder arthroplasty should not be so far away from a normal shoulder. We should keep in mind that our goal is to be as close as possible to a normal shoulder, even if it's a reverse one. As you can see here, you have a normal shoulder, and if you medialize, as you can see here, you can lateralize a bit on the humerus, and you can see that here. That's what you have with biologic lateralization, and that's what you can achieve and the best way in order to be as close as possible to the normal shoulder is to have a 2/3 sphere, as you can see that. So this is an example. This is an example of the perfect circle. This is an anatomic arthroplasty, and this is a reverse arthroplasty. And if you try to find this perfect circle, you can reproduce it even with a reverse shoulder arthroplasty. So that's what I call an anatomic reverse. And if you look at the first prosthesis from Grammont, it was a 2/3 sphere. Amazing. So now we know that this anatomic reverse should be inlay with an anatomic neck shaft angle close to 135 with a metallic glenoid lateralization. And the key point is really probably this 2/3 sphere. Thank you.
Again, as I mentioned, we're going to kind of summarize some of the stuff you just saw and then take it to the next level. So Paul Grammont here, as you just heard, did not invent the reverse, right? So we saw this slide here with some of the early near mark prostheses. So why did they have this lateralized design initially, right? Even though these failed until Grammont came up with his genius innovation of medializing things. Well, the reason they failed is because the fixation was not up to the task at that point. You can see these early designs with this cemented keel hollowing out the glenoid vault. The technology in the 1970s and 1980s is not what it was in the 2000s, right? The metallurgy, locking screws, these things did not exist at that point. And eventually, as you saw here, his design was to say, hey, wait a minute, let's give up a little bit on range of motion. Let's give up a little bit on impingement-free range of motion, and maybe we can get something where the glenoid doesn't always fail. And that was the genius of Paul Grammont. I think that all got mixed up, as you just saw, in the fact that, oh, maybe we have to medialize the center of rotation, right? And that's not really the case. That's not why Grammont's design works. The reason reverse works is because it's a semi-constrained bearing. The whole thing about recruiting the deltoid fibers is really not, obviously, as we have multiple designs that are lateralized, clearly is not why the reverse works. So why did these early designs all have that lateralized center of rotation, as you saw? Better impingement-free range of motion, better cuff length tendon relationships, right? So that Blix curve, we all remember from med school, right? If you're trying to grip something and you bend your wrist as far as you can and then try to grip, you can't do it. Try it right now, it's impossible. You need that link tension, but the fixation had to evolve over time. So this is an early study from Mark Frankel's group where they looked at the hierarchy of design factors. So humeral socket inclination, lateralization, tilt, sphere diameter, all the things that you might look at. And I would invite you all, many of you I'm sure are familiar with this article, but it's worth a reread, JBJS 2008. But the bottom line is basically they went through a simulation, and the factor that was most important, there were a couple things. Obviously, you wanted to keep the sphere low, a little bit of slight inferior tilt. But if you can see on the left side here, the humeral socket or neck shaft angle was really, really critical. So that 155 design, which was needed for the Grammont design to avoid instability with that medialization, but also cause the notching, that's going to lead to defects in adduction, right? And then you can see here that center of rotation offset, again, the lateral histogram there, you can see very, very sensitive to center of rotation offset. You get a lot more range of motion with just a little more offset. Again, because you can imagine that sphere can that socket can articulate with the sphere. All right, so we know the 135 and the lateralized center of rotation is better for impingement-free range of motion, but what about that fixation problem? So exactly as Philippe showed, in this study, this is a key study. So when you have only a post and only peripheral compression screws, you do need, that's fine. It has to be a medialized center of rotation. But if you want to lateralize that off the glenoid face, you have to use peripheral locking screws. But if you do that, this study shows that, that you're going to get the same amount of micromotion and the same amount, and then we've shown clinically the same amount of low base plate failure. So in other words, it's okay to lateralize now with the technology we have, but you need that, again, better metallurgy and better, you can't use 1970s technology to do a lateralized center of rotation reverse. I think that was the error in the later part of the last century. So, so what about the clinical results? So this is Mark Frankel doing his first reverse. It was a custom designed prosthesis. I don't have a picture of that one. I have the second patient here. You can see some pretty significant anterior superior escape with a bipolar hemiarthroplasty, which was the standard of care treatment in the US at that time. And you could see she's smiling. I wouldn't say her function is super great, but she's happy with her early reverse. And this design evolved over time. So maybe we need a little more systematic than one patient. How about this study here? Derek Cuff and that group showed, they looked at the original patients in a very well done IDE study. This was part of the FDA approval for this device. And they showed which is a design that's very similar to the design that is on the market today. 6.5 compression screw, monoblock base plate, 5mm peripheral locking screws, and a 135 humeral socket inclination. So essentially the same device you're looking at today with a few little minor changes. Great results. It's important to know that about a quarter of the patients in this paper were revision arthroplasty. So, an IDE at that time, the reverse at that time obviously was a salvage procedure, right? So this is the kind of patients that were being treated with this. This is in no way cherry-picked patients whatsoever. And the bottom line is what you can see is they did really well. So it's a busy slide here, but the forward flexion improved, abduction improved, external rotation improved, and the ASCS score improved, all statistically significant, all clinically significant, I would argue. And most importantly, if you look in the upper right there, 100% base plate survival, no base plate failures with the current design. So that's key. So in other words, the lateralized design works. The survival curve was excellent. There were a few periprosthetic fractures and a instability event, as we see with reverse, but 94% survival at 60 months, so 5-year survival. Okay, 5 years pretty good. But what about 10 years, right? Do we have 10-year results? The answer is yes, we do. So this is the same cohort of patients, followed now 5 years further on. So many of these patients are in their 80s. 24 of the patients had passed away in that 10-year period that they were being followed. And the bottom line is, again, these is a very challenging population, but 94% implant survival rate. Just think about that. So again, a quarter of these are revision arthroplasties, 94% implant survival rate at 10 years. That is incredible data. And I would argue, obviously we'd like to know even further beyond 10 years, but as far as what we have in our field of orthopedics, 10-year data I think is something we need to take seriously. So there's a periprosthetic fracture and a dislocation, but basically the patients did very well. You can see here, and again a busy slide here, but the ASCS pain scores were durable. So from 5 to 10 years, that's the middle column and the right column. The flexion did decrease a little bit, so from 144 to 126. Now these patients, they had the surgery when they were 70, now they're 80 at this point. So that was attributed maybe to age, maybe the deltoid tires out. We don't know, but I think it's still clinically they were a lot better than their pre-op average of 70. So they were still 126 of flexion, and most importantly, the implant stayed in place. So it's radiographic follow-up looked good. It's hard to compare like the 10-year data with the Grammont design from Favard at all, because as Europeans are aware, the constant Merle score is the standard of choice score for shoulder scores here in Europe, and in the United States we use the ASCS score, and you really can't compare those. I've overlaid them here. The orange curve is the constant Merle, the red or the blue is the ASCS. I don't know. They're both good. The bottom line is both those curves are flat. And really the good results are fairly consistent over time with minimum 9 years in the Favard study and minimum 10 years in the Frankel study. So in summary, the Enomus design is the most studied reverse design currently on the market. This design has changed very little. There's been some improvements. It's now monoblock. The ingrowth coating is grippier than it used to be, but as far as the key things of that lateralized center rotation, that inset humeral tray, really has been the same design that we've seen in now 10-year data. It's ideal for recreating the range of motion, and we have durable 10-year results. So I appreciate your attention, and thank you for welcoming me here today.
Yes, thanks for inviting me for this talk about this inverted bearing reverse total autoplasty, fewer complications and improved outcome in long term. This is my disclosure. I work together with Mathys since 20 years in the developing of the reverse and the fracture prosthesis. So I know something about that. What is about the new designs? It's in revolution or it's in evolution. We heard that more various inclination of humeral resection, clinosphere with different offset in eccentricity, lateralization of the humeral component, increased offset, and we have platform systems with the option for conversion. But we also can change the materials. The reversal of the tribological pairing is possible, so we can use a PE clinosphere and a ceramic inlay. Our goal in the development of this reverse prosthesis was the reduce of PE wear, and for that, first we go for an inversion of the material, so we use a PE clinosphere and a cobalt chromium inlay. Later on, we get a new material. It was the ceramic inlay with 5 less wear, and we have this highly cross-linked polyethylene with Vitamis. And by the surgical technique, we are able to reduce the mechanical notching by centric drilling with eccentric positioning of the glenoid. And of course, we have 3 sizes of the glenosphere, so we get at minimum an overhang of the glenosphere of 3 mm. But if you use a 42 glenosphere, it's 6 or 7 mm glenosphere overhang. The first study was done to find out what is about the wear comparing to the standard rTSA. It was this gravimetric wear versus abrasion of PE inlay due to notching. And the group found out the 4.62x higher loss of mass from PE inlay abrasion compared to the gravimetric wear. And the first clinical study was published by Ulrich Erlenbusch, one of our senior authors, 2-year follow-up at this time, 113 cases. And we saw the shape of the notch matched to the shape of the humeral inlay. And the bony defect was mainly away from the base plate. And it was independent from the glenosphere size, the surgical approach, the glenosphere overhang, but it was significant, correlates to the PSNA angle, because with the higher angle we have, of course, much more notching. And we have done several studies. This one from Thierry Joudet in this book chapter published about 358 cases, 78 months follow-up, mean age of the patient 74 years. And we saw a significant improvement of the clinical outcome after 7 years, but the notching was not progressive over the time. So I have no notching in nearly 3/3 of the patients, and nearly 20% was in grade 1. But we have seen a very good survival rate over 10 years with the cemented stems 95% and with the uncemented 91%. I've done another study regarding the severity of the glenohumeral arthritis, and we formed 2 groups, group 1, grade 1 to 3 Hamada grade, and group 2, grade 4A, 4B, and 5. Grade 5. It was also published. And if we compare these groups, there's not significant difference between the groups in the clinical outcomes, complications, and survivorship. And we saw a high implant survival for all these disease stages of massive rotator cuff tears over the time. This is a typical case of a scapular humeral notching. What does it mean? It starts on the scapular side, and later on, you see this bone resorption around the proximal stem, and that's really a big point. I can solve a lot of problems around the glenoid, but if I have such a massive bone loss on the humeral side and get a loosening of the stem, in my mind, that's a much bigger problem. This is a typical case of a scapular notching with IB rTSA. It's beginning at 1 year postoperatively, and you can see here after 2 years the shape of the humeral component, and it's not extend to the base plate, and later on, after 7 years, you see this sclerotic line developing at this time. We published that. Our thesis was the scapular notching does not affect clinical outcomes and complications at mid to long term, and we included 229 shoulders, mean follow-up 87.7 months, and we found no notching in 65% and notching grade 1 in 28, and some notching cases at grade 2 and grade 3. And it was the notching classification of the Wo. We asked him that we can adapt it. And this the same as the concept Merle score over the time. We compared the notchings versus non-notchings, and there was not significant difference between this, both groups after 24, 48, and 84 months. And if we look at the clinical outcome at the final follow-up, you can see we have these both groups, no notching and the notching group. It looks a little bit better for the no notching group, but it was not different, not significant different was regarding the constant score, the ACSAS score, forward flexion, abduction, and a visual analog scale. So the Kaplan-Meier survival is also a very important point. Complication rate, survival rate, notching versus non-notching, no significant difference over 10 years. This is a case for my hospital. I operate this patient 2010 and 2011, and you can see the X-ray and the function after 10 or 11 years. So in conclusion, we have now mid to long-term results, and the patients with notching had equally good clinical outcome and low complication rate as without notching, but we found a distinct type of mechanical notching without signs of PE-induced osteolysis. Of course, the lateralization of the center of rotation maximized the range of motion, increased the stability, and prevent notching. Pascal Boileau, we saw this paper before in this first presentation. Pascal Boileau saw notching with low BMI, insufficient inferior glenoid offset, and superior inclination was seen in these cases, but we think scapular notching does not affect clinical outcome with this inverted bearing, reverse shoulder arthroplasty, and complications. But now we can add our next step. We are now also able to build this bone graft, and this is also a case for me, for my hospital, and it's very easy to remove that, and more I use that. And I show you this last case. I operate this patient a couple of weeks ago. 79-year-old male, 3 months ago, he get this displaced anterior glenoid fracture with this huge bony defect of more than 30% of the glenoid surface. And primary with this descender humeral had very bad function, and intraoperatively it looks so, but we decide to go for this stepped bone graft and do that with the uncemented stem and with this bony increased offset system.
I'm just here to give you some concern that I have regarding the future, and this will be the topic of this presentation. So, for me, things that has changed dramatically during these last 15 years are probably the surgical indication, surgical approach. I'm not going to spend a lot of time on this topic, but we develop minimally invasive approach like the subscap horn, and in some cases this has been a game changer. And I would like to remind you what is now acquired and what is the future. So surgical indication, you need to know that I trained with Gilles Walsh in 2007, and Gilles learned me how to implant a reverse shoulder arthroplasty. And when I came back from Lyon from Lyon to Geneva in 2007, my boss at that time said to me, you know, Alex, your crazy prosthesis, in 5 years, nobody will implant it anymore. And obviously, this was not a wishful thinking. Because today, the reverse represent 90% of my indication. So in 2007, when I was starting a presentation and talking about indication, my indication where it was the best indication for prosthesis was when there was nothing else to propose to the patient, okay? And today, this is my indication. It's always, except maybe if there is something else to propose to the patient. So you all know this list of surgical indication. And honestly, the reverse has changed our life. In 2005, when I was on call, God talked to this guy and said, you should kill yourself. So he tried to kill himself, and I spent the night removing bullets from his shoulder, doing some kind of coagulation. And 2 years later, I implanted in this patient with Gilles Valche a reverse shoulder orthoplasty in Lyon. And this is the 10 years result. It's not unbelievable, but this patient has now a family, he is happy, he's a pizzaiolo in Geneva, and even if it's not perfect, I mean, the reverse allowed us to give him a new life, you know. And I'm just showing you this case because I will go back on the indication, and I think that there is a new kid in the block. And this is the primary reverse shoulder, the reverse for primary osteoarthritis. And this is something new. I'm not going to summarize all the articles that has been published in 2019, but since 2019, no article demonstrated that the anatomic is doing, at least in the long term, a better job than the reverse. No one. And interestingly, even if the anatomic from time to time is doing better, namely for internal rotation and in the back, at 7 years, interestingly, the curve cross and the reverse suddenly is doing a better job, probably due to glenoid loosening of the anatomic component. So this was the first point. Surgical indication has completely changed this last year. Then I would like to talk a little bit about the stem. So you know we have stemless, short stem, long stem, and I'm using since 2007 short stem, and I revised one stem since 2007, and this was due to a technical error. The stem was undersized, and this has been recently confirmed by Mark Frankel. He has only 2.8% of his problem on the humeral component. This is really insignificant. So today, for me, the standard stem for easy cases, primary cases, is something that we should give up. There is no more indication for this time of stem. And what about the stemless? So the stemless in Europe, we have a great experience for anatomic with honestly very good results. But we don't know yet if it's the same for the reverse. And please read this article that just has been published by Philippe. It's a multicentric study analyzing one design, the FX solution one, with peg fixation, only design. And the result, I wouldn't say that they are alarming, but it's clearly not satisfactory, with quite a high rate of complication, high rate of reoperation, and most of these reoperation concern the humeral component. For me, clearly today, for the reverse, we haven't found the solution. I know that Mathys is working on this topic, and they will come with a great inlay prosthesis soon. But today, I will be very worried and I stop personally to use this kind of device. And now, let's talk a little bit about long term, because for the future of the reverse, this is the key. Who amongst you loves cement? Question. Who cement prosthesis? Okay. So just to give you one example of the nightmare that we are going to have in the future. This patient has been operated in 2006, and she came to me in 2018. She could not anymore. She had 12 years of nightmare. She could not anymore. So I did this revision, and honestly, I fight with the cement. It has been not an easy surgery. 2018, and she came back in 2020 with this. So still a lot of cement distally. So I did a revision, and I used this device. So long stem, APC, plate, and I was quite happy with what I did. It's not perfect, but I was, however, quite happy. And she came back in 2022, excuse me. So I did this in 2020, and she came back in 2022. So fatigue fracture distally, disassembly, because you need to have a monoblock for these difficult cases, and no more APC. So what do? I don't have time to show you the revision, but I just would like to share this postoperative X-ray. So I decided to use a long monoblock revision stem, and I really wanted this stem because this is the only one that I know that has a distal locking solution, and these two screws had to help me to solve the solution. However, this is not a good design because this stem is too short. It's too short. We don't have long stem. It's clearly too short. So what did I learn? I learned that the plate that we have to reconstruct the bone on the humeral side, we don't have good plates today. We don't have good stem, and we are going to face a lot of very difficult situations. So no adequate plate. This plate, okay, they are a little bit anatomic, but it's too short. The screws are too weak, and so on. And this is a case that I did on Tuesday. So see, non-union. It was more non-union of this mid-shaft fracture, and I used this plate. Okay, the result is fine, but I only have one screw because it's the design of the plate is not great, and I couldn't use a long philos because I think that it was too short. I did a measurement and it was too short. Let's talk some minutes about planification. We know that planning is essential. Why? Because this is two scapula of patients living on Earth today. And what is right for one patient is probably not right for this one. So we took 10,000 of these scapula, and with a mathematical regression, we transformed these 10,000 scapula into 7 models. And then you can implant in these 7 models different prosthetic configurations. So lateralization of the glenoid, distalization, size of the glenosphere, and so on. And whatever the design that you choose, if you look at abduction, whatever you do, you will obtain quite a good abduction, okay? But it's not the case for adduction. There is dramatic change for adduction. We are all able to understand this, okay? But then if you look at everything, all the range of motion at the same time, maybe I'm stupid, but I'm not able to understand anything here. And you understand that this is why for these cases, we will need AI. AI will tell us for the one specific anatomy and to the expectation of your patient, which design you need to choose. Because alone, I'm not able to do this. There are more than 40,000 possibilities. Okay, so this was for the planning. And then the planning of primary surgeries. And then this is the planning of revision surgeries, the next step, you know. I did this case Wednesday, so 2 days ago, glenoid loosening in a patient with rheumatoid arthritis. And we can plan this kind of prosthesis, okay? There is today software that allow us to see the previous prosthesis, and you can remove the prosthesis, maybe put another one. And if you remove everything, you will see that there is no more bone. Okay? Here, there is no more bone. Nothing. You don't have posterior wall. So, okay, this is a planning. But the problem for these cases, the planning is clear, but you need what we called guidance during surgery. And it's very difficult to have guidance because today it does not exist. So I took the iliac crest, first step. And then this is an article that we published with Philippe. I also took the coracoid process and tried to reconstruct the glenoid to have some bone in order to implant the glenosphere. So I took the coracoid process here. You just detach it. And then I will expose the glenoid, and you will see that it's a disaster. There is just a thin layer of bones. Where do you put your pin? It's a revision prosthesis. You don't know. You don't know where you should put your pin. You have no idea. So I grafted all the iliac crest posteriorly and then fixed the coracoid process anteriorly. And you just pray God, put your pin, drill, and hope that you will obtain some kind of stability. And I had 2 very good screws, so I decided to go on and not to do a 2-step surgery. But I think that we are not really prepared. So this is the X-ray of Wednesday, X-ray of this morning. For the moment, I hope it will continue to go on this way. So today, what is acquired? What do we have? I think that we have AI. It's here. Whatever you do, it's here, and this will clearly help us to make our life easier in the future. Something that is also here is to adapt prosthesis to the bone. Before we were adapting the bone to the prosthesis, and probably that in the future we will be able to have this kind of implant. Another thing that we have, and this is for me very important, when I had difficult cases in the past, I collected my cases, and once per month I was taking my car, I was going to Lyon, presenting my cases to Gilles Valge, having one advice, and I was going back to Geneva. And today, with this kind of platform, this is BMed, but there are other ones, you just post your case, and the next day, you have 10 answers, okay, of guys that you don't know, but interestingly, you always have very good advice. And for my patient, it's interesting because I don't say anymore, I think you should have this type of surgery. I say, okay, I look with friends, and to summarize the main advice, I would like to propose to you this surgery. And for the patient, it's very good because he knows that you are not alone, you have a team around you. And what about the future? And this was the main topic of this presentation. I think that the future is stemless reverse shoulder arthroplasty for primary easy cases or malunion, but we need to wait and to confirm follow-up first. We need to have better stems, so longer monoblock stems with a distal locking possibility for complex revision. We need to have better plates for periprosthetic fractures, and we also need to navigate the humerus. This is the key if we want to implant stemless prosthesis. And this is the last slide. I think that we need to start to plan with MRI, because with MRI we will have almost the same information, but also probably more with eventually the stiffness, but also the muscle function. And I'm not only talking about atrophy, fat infiltration, but also sarcopenia. Robotic, honestly, I don't know. I used this kind of device, Brain Lab, in 2005 when I was still doing knee surgery. It has bring nothing to the clinical result, 0. And all these machines are now in the garage. So I'm still waiting for the robotic, and probably that the future is to have the possibility to operate without tracker. We have now a certain system that allows us to navigate with trackers, but first of all, it's not done for revision surgery, and honestly, we need to have automatic superposition. This will be very helpful for the difficult revision. Thank you so much for your attention. I don't know if you have any questions or comments.
We have time for discussion.
You talked about adding, when you need to change the anatomy, let's say a retroversion of 25 degrees, you want to put a piece of bone on it using the humeral head, for example. In the DJO, in the current design, you're putting let's say you make a jig and you put your KY in, and then you need to put a tap on it, but it's not cannulated. So how can you know exactly where to go with the tap when it's not cannulated? This is one. The second one is with the bone graft you want to add, the length of the screw on the base plate has only one size. Now, if you want to put a piece of bone in addition to that, and you want the end of the screw to penetrate the front of the scapular body, you won't be able to do it. So I think you need sort of an added one in order to have a good purchase.
One thing is, because it's a monoblock base plate design, you do not need full backside coverage of that. So biomechanically, it's been shown in the lab, you only need 50% of that base plate to be sitting on bone to get the same effect as if you have full coverage. For me, I like to ream till I have about 2/3 of the bone resting on there, but it's not like a multi-piece design where you need the entire thing sitting on there, so that's point one. So it's okay to leave it a little bit off. Number two, your point about technically if you have a bone graft, you're absolutely right. So they have cannulated taps that your rep can get for you for the case that is not part of the standard instrumentation set, but those are available if you want to use that and that as a one-off thing. The length for the screw is a great point. There's 2 points there. One is the thing you didn't point out, but I think you're probably aware of. There's no coating on the screw. So if you're going to use a bone graft, you don't want to use the DJO with like a bio-rTSA type technique, because that screw has no ingrowth surface on it whatsoever, right? So if it's sitting fully on the bone graft, then you are relying on that 100% bone graft ingrowth for that to work, because it's not like there's an HA coated post or a coated post going deep. So number one, if you are going to use a bone graft, you need some of that back side of the base plate to be sitting on the native bone, in my opinion. Number two, the length of the screw, that's a thing that's currently under development. I can't say much more about that, but it's a great point. You need to get that screw penetration. Now, if you don't get good screw penetration with that straight on, deepest shot, it's okay to have it off a little bit. Mark Frankel's talked about the alternative center line and kind of putting it so that the screw comes out the anterior and posterior part of the vault. So you may have to move your hand position a little bit, but these are all great points.
Regarding the screw and the bone ingrowth, I started to screw my base plate for difficult revision cases, and this is what people were telling me. It will fail because you don't have bone ingrowth around the peg, and I published it in November 2021. This is wrong. If you have a very good bite of your screw and an inferior tilt, you will have bone healing. And I think that the terrific compression that you obtain at the beginning is clearly as much as important that a teeny bone ingrowth. Particularly because if you have a glenoid, a very bad glenoid, don't forget that the bone ingrowth will be around a very teeny pieces of your post. It's something like 2-3 millimeters, not more. So all these theories are bizarre, and I prefer to have an unbelievable compression rather than a bone ingrowth on 2 millimeters.
And my question is about the affinity inverse. When we started to use the softwares, we learned in most of the standard cases of the cuff arthropathy, we have some retroversion in the glenoid side, even if our eyes can't see that. So I see you have base plates with double pegs or one long pegs, and you have a device to take off bone grafts from the heads. So how is your decision making about the decision which base plate and when we need to correct the retroversion?
I start with the double back base plate in 2008, and I liked it very well because it's very stable. It's really, really stable, and so we have only one size of with the base plate, with the pegs. But for me, it's the perfect solution for normal glenoid retroversion without any retroversion. Sometimes I can remiss a little bit if I have if I need a correction. The central peg base plate I use only now for if I go for bone grafting, yeah, only for these cases. And I start with this bone grafting with the lateralization, sometimes in osteoarthritis cases, but it does not work very good in my hands. So I do that now if I have a cuff arthropathy with more bone loss, and when I can correct it, because we have also the possibility to correct the graft, so you can get an angle of 7 or 15 degrees in your graft. So if you have a bone and deficiency on the posterior side, you can change that with the graft. That's my opinion about that. Normally I like the double pack. I know if you start with that, it's not so easy to bring a double pack in, but this instrumentation is very easy. So you have to be flush with your guide to the inferior border of the bone, and then you'll be normally perfect inside. But what I do now more and more in difficult cases, I do intraoperatively use the fluoroscopy and check my key wire. I've done a lot of revisions, much more than much other in Berlin. And in this case, I look, I would like to have the perfect situation for sitting for my central pack. And in this case, I check my position in both sides, in the axial view and in the AP view with the fluoroscopy. And sometimes I changed it after that.
Do you think that in practice nowadays, every single reverse should be lateralized, or we still have some patients that will have a better rumor motion with a medialized prosthesis?
Also in theory, with computed model, interestingly, the most important factor for global range of motion is not lateralization, but it's distalization of the glenosphere. So the inferior eccentricity is more important than that glenoid lateralization. In theory, you should lateralize, and you should have something like 5 millimeters of inferior overhanging. Okay. Practically, and there are now several studies that has been published, result of a medialized glenoid are very good, and you may have a better external rotation if you lateralize, but this is the only factor that Philippe Collin found in his study, if I remember well.
Yes, and I think that in the future, we will probably not try to adapt the patient to our prosthesis, but to do the opposite. I think that, for example, if you have a 85 years old lady and with a cuff tear arthropathy, you just don't mind about the notch in 10 years. What you want is something very quick and safe. And you want to assess the cuff. So that's why, for example, for this kind of patient, I just don't mind, because I want to avoid spine fracture. I want to avoid this. So I will go for a prosthesis, which I know that it would be very good for her, for example. So that's why I think that Grammont design it's not over. I think if you have some risk to make too much lateralization, and then we know that you could be at risk for dislocation or something like that, I don't mind to be medialized, because this is the aim that I want, because I don't mind about the notch in 10 years.
Alex, we saw that you use coracoid graft to bone graft the anterior part.
Yes.
And like Latage, did it cause any instability after this kind of bone graft? Meaning that if it didn't, sometimes when we put the reverse in, we'll feel some click around the humeral tray and the conjoint tendon. If your technique didn't cause any problem, next time when I facing the click between the humeral tray and the conjoint tendon, can I cut the conjoint tendon?
So this is a very good point, Joe, and I think that the anterior impingement is an underreported complication. This is something that has recently been described by Jonathan Levy from the NFS team, and we have clearly more than we expect. So I don't care to cut the coracoid process for two reasons. First of all, I will avoid an impingement. The second thing is, in abduction external rotation, you may obtain, it's not a sling effect, but it's it's not a hammock effect, but it's a sling effect with the conjoint tendon coming in front of the shoulder. So for me, it's not a big deal to cut this tendon. Then for primary cases, I never did it routinely, to cut the conjoint tendon. I think that I will try first to decrease the glenoid side. I will try first to do a tuberoplasty rather than cutting this tendon. But if nothing works, just cut it, yes.
I like Alex's point. I will say that I think the most important way to eliminate that anterior impingement is you think about what causes it, right? So it's if you have an onlay humeral tray or a lateralized humerus, that lateralization is going to be anteriorization when the patient is flexed anteriorly. So I think for me, having an inlay design really helps eliminate that possibility. I've only seen that previously when I use an onlay design in my hands.
Impingement anteriorly, you do see that with those onlay designs, and one of the things I have done actually is just take a small sliver of a third of the conjoint tendon and then just fold it back onto it and suture it back on. And that's one of the ways you can deal with it after you do a tuberoplasty and it doesn't work. It's something that Jeff Hughes and I do back in Australia. And it
very
helps with that.
interesting. I also saw in double AOS some guys now routinely cut the pec minor because they say that for the scapulothoracic joint this may have an importance. So they systematically cut during a reverse the pec minor. I don't have any experience.